Oui, bonjour à tous. Bienvenue à ce colloque, à notre rendez-vous annuel des familles et des chercheurs. Alors, comme les années précédentes, le
Family
colloque se
researcher
déroulera en
session.
4 sessions
This
d'environ
is going to
2
be
heures 30.
2 days.
Deux
We're together
sessions
for
auront lieu
two
aujourd'hui et
days,
les
four
2 autres demain.
sessions. We have two
Sachez
sessions
que
today.
vous
We have
êtes
two sessions
plus de
tomorrow.
400 familles
We have
inscrites à ce
more than
colloque provenant
400
de 35 pays
families who
différents.
signed up from
Je crois que c'est un
35 different
record
countries,
et
which
cela
I
montre
think
surtout
is
l'intérêt
is a
grandissant
record high,
pour ce
and
type
it shows
d'événement.
the growing
Le
interest
meeting, comme
for
l'a dit Audrey,
this
est
type of
traduit
event. As
simultanément en
Audrey
7
said, this
langues.
meeting is
On a ajouté le
simultaneously
japonais
translated
cette
into 7
année. C'est
languages. We've
l'occasion
added
pour moi de
Japanese
saluer la
this year.
présence de
As a matter of fact, I would like
Rie
to
Omna, la
welcome
présidente de
Rie
l'association
Omna, who
japonaise
is the chairman
AFICO,
of the
qui participe
Japanese
pour la première fois à notre
Association,
colloque
A
annuel.
Future, who is attending this
Cette
event for the very
association
first time.
rassemble les familles japonaises
And
concernées par
the,
l'adrénoleukodystrophie et
her
l'adrénomyeloneuropathie.
association brings together Japanese families
Elle fait
affected
beaucoup de
by
choses
ALD
pour
and
l'accompagnement des
AMN.
familles au Japon.
The
Je remercie
organization
l'équipe
has
d'ELA qui
been
a
providing
travaillé à
great
la mise en œuvre
support
de ce
to Japanese
colloque.
families. I
Audrey
would like to thank
Boyer, que vous avez
the
entendu, qui est
ELA
responsable
team
du
that has worked
département
on
recherche sur l'ALA
organizing this
international,
conference,
Laure
Audrey
Philippe,
Boyer,
qui travaille
Laure
avec elle,
Philip, who
Hervé
works
Pierrat,
with
qui est la
Audrey,
solution
Hervé Pierrat,
informatique
who is our
sur cet
IT
événement, mais pas
assistant
seulement,
for this
tout au long
event,
de
and not
l'année,
only,
et
but
Jean-Luc
he's really
Corti,
working with
secrétaire
us
général
year round. And
ELA
Jean-Luc Corti is the
international, est mon
Secretary
ami de
General
toujours.
of ELA International.
Je remercie également
And I would
l'équipe
also
des
like to
interprètes
thank the
coordonnée
team
par
of
Isabelle Brusset, à laquelle je
interpreters
laisse la
represented
société
by
pour
Isabelle,
parler,
Isabelle Brusset,
avec qui
who is
nous
with
collaborons depuis plusieurs
Pourparler.
années maintenant.
Pourparler
Enfin,
is
je
a company
souhaite
we've been
remercier
working
très
with for several
chaleureusement
years now.
les
I would
médecins
also
et les
like to
chercheurs,
warmly thank our
non seulement pour
doctors,
leur intervention ce
researchers, not only
week-end,
for
mais aussi pour
their
leurs efforts
contributions
de
this
recherche
weekend
et de
and for
soins,
their great
d'attention
efforts,
apportée
both
tout au long de
in the field
l'année
of research
à
and
notre
care
communauté de
provided
patients.
to our patient community.
Mais au-delà de notre reconnaissance, je pense que
Beyond
l'une des
our
meilleures façons de les
gratitude, I
remercier
think that one of the best
est
ways
de
to thank them
financer leurs travaux.
is to
C'est ce que
fund
nous faisons. En
their
2024, par exemple,
research. And this
ELA
is what we've
International
done.
a financé
Uh,
15
in
programmes de recherche
we've
pour un montant
financed
de 1
15
700 000
programs
euros.
for a total amount of
Nous faisons
1.7
tout
million
depuis la
in
création d'ELA en
2024.
1992.
Since
Cela
the
représente
very
quand même 50
since the
millions,
first day
et
of
plus
ELA
même
in
50
1992,
millions et
we've
500 000
invested
euros
50.5
d'investissement dans la recherche
million
médicale
euros invested in medical
pour le
research,
financement de 586 programmes.
which is
Alors même
the money
si ces
which was
chiffres
necessary for
sont importants, en tout cas pour
586
nous,
programs. So
ils
it's a
ne
lot
disent
of
rien
money.
finalement de l'engagement
The numbers are
exceptionnel
significant, but
des
they say
membres de
nothing
notre
about the
conseil
exceptional
scientifique
commitment of the
international.
members of
Et
our
c'est grâce à la
International
qualité quand même de
Scientific
leur
Council. And
travail
it is
de
thanks
sélection
to
des
the quality of
programmes,
their
de
great
suivi
work
rigoureux de
of
ces programmes,
their
que nous
selection and
pouvons,
rigorous
nous,
monitoring of
garantir
programs
l'excellence des
that we
projets
can
financés par
ensure
ELA
the excellence of
International.
projects that are funded
Et
by
donc
ELA
finalement,
International.
rassurer nos
And,
mécènes et nos
and
partenaires sur le
therefore
bon usage des
make
dons
sure
qu'ils nous
that good
confient.
use is made of the
Ces
donations
chiffres
coming
ne
from
disent
our
pas non
partners.
plus le formidable
The
travail
numbers
de réflexion,
also fail to
d'argumentation
reflect the
réalisé par
tremendous
les membres
amount
de
of
notre comité
thought
d'éthique,
and
un comité que nous
argumentation
avons créé
carried
en
out by the
2023
members
et
of our
qui
ethics committee.
rassemble
In
des médecins, des
2023,
chercheurs, des
the
dirigeants
ethics
de
committee brought
biotech,
together
des
researchers,
spécialistes de
medical
l'éthique,
doctors,
des
ethics
parents dirigeants
experts,
des
parents,
associations ELA.
non for
Je les appelle
and
plutôt les
ELA
parents experts.
representatives. I call them
Ces
parents or
dernières
parent
années, le comité a
experts.
travaillé sur deux
And in the
sujets
past
très
years, we
importants
worked on two very
et même
important
vitaux au sens
topics,
propre du terme,
absolutely vital
puisqu'ils peuvent
topics,
les questions sont liées.
life-saving topics.
Le premier sujet, c'est le
The first
dépistage des
one
leukodystrophies
is
à la
the
naissance
screening of
et le deuxième,
leukodystrophies at
l'accès aux
birth,
nouveaux
and the
traitements.
second one is
Alors,
access to
concernant
new treatments.
le premier sujet, le
I'd like
dépistage
to
des
say a quick word
leukodystrophies,
about
le comité
the
d'éthique
screening of
en
leukodystrophies, and
2024
the
s'est
ethics committee
clairement
in
prononcé en faveur du
2024
dépistage à la
clearly
naissance en population
supported
générale de
birth
deux
screening for the
leukodystrophies,
general population for two
l'adrénoleukodystrophie et la
leukodystrophies,
leukodystrophie
uh,
métachromatique.
ALD
Il
and
a rédigé un
MLD.
avis documenté
It
sur la question
drew up
et
a
ce
documented
document
opinion on
existe
this issue,
déjà
and
en
this
six
document
langues.
is
La
now
France s'en
available
est
in six
emparée
languages already.
tout de suite, dès l'année dernière.
France used it
Elle l'a utilisé pour
immediately
déposer l'an dernier
and
une demande de dépistage
uh,
à la naissance auprès du
requested
ministère
a
de la Santé
national
français.
screening program with
La
the
bonne
French
nouvelle est
Ministry of
tombée en
Health.
début d'année
And the good
2025
news
puisque
came at the
cette
beginning of
demande a été retenue.
2025 because
Et
this
donc elle va être
request
évaluée cette
was
année par la Haute
is now under investigation by the health authorities in France. It's just one example. It's the first step for the implementation of a national screening program for newborns. So this example, I think, is important for all of you, non-for-profit organizations, that this is the right time to reach out to your local health authorities and make this request for systematic screening. I know the Germans have made tremendous progress, but I think they're pretty much the only ones in Europe, except for the Netherlands. In the Netherlands, they already have screening for adrenoleukodystrophy, but it's only limited in Europe. I think specific efforts need to be made. The second topic the committee is working on, as I said, is access to new treatments. Conclusions have not been released yet, but I can tell you that the subject is very complex. In summary, all families know that there are very, very few new treatments in leukodystrophies, and when treatments exist, they are difficult to access. And to have more treatments, which is necessary to take care of our children, partners, and friends, we must relentlessly support medical research. We have to do so, especially in a context in which it is threatened. And the movement, Stand Up for Science, which started in the US, I'm sure you've heard of it, it has been growing everywhere. It's growing in Europe and elsewhere in the world as well. It opposes significant budget cuts coming from the US government against its own public research system, which they have so many good reasons to be proud of. Biomedical research in the US is undoubtedly the most important one in the world. It is important for everyone, really, for every single person. And again, I want to tell physicians, doctors, and researchers who work on our diseases and who are concerned with our children, and on whom all our hopes rest, that they can count on our unwavering support and gratitude. I think we can give them a very warm round of applause. With that, I would like to wish you a wonderful conference and a great weekend. Over now to Florian Eichler, who is going to chair this the next session on ALD and AMN, and who is the chairman of ALA International, of the Florian, over to you. I don't know if you can hear me. I think the floor is yours.
Thank you, Guy. That was wonderful. And a big shout out to ELA and this international community here. I'm delighted to see not only Guy, but many friends and scientists here. I would echo what Guy said. It's very important to have the forums like this where we all come together, and not only the scientists, but more importantly, the families. I think, as Guy said, these are difficult times, but it also, with change comes new opportunities. At a time when there's so much talk about national interests and national sentiments, we have to remind ourselves that diseases we fight are international, they're global, and we need to come together as a global community. And much credit to ELA for really establishing this international community in the leukodystrophies, and also bringing together a scientific community and committee that every year looks at grants and looks at science and thinks together about what is important. As Guy said, there are not enough treatments, but there is new technology emerging, and these new technologies give us hope that some of the diseases that have affected patients and families for so many years will be changed, altered, maybe transformed. and access is difficult, but progress sometimes can be fast, but at other times it has to be slow because we don't always know what the outcomes will be. And safety is tantamount. And so we want to provide access, but we also want to be careful as we are entering new territory where we often don't know what will happen until we've done careful trials to ensure safety and the right inclusion of patients. So without further ado, I'm delighted to introduce our first speakers. It will be Stephan Kemp from the Netherlands, a very well-known researcher who's contributed so much over the years and been really a pillar of this community. We're very proud of all the work he's done, and also that he has brought Triana Amen from University of Southampton to us, who is really a new force in the field and somebody who's lending so much knowledge and bringing new insights into ALD through her advanced cell biology expertise. So take it away from here.
Well, thank you, man, very much, Guy and Florian. And thank you again for inviting us. I will not take too much time because the really interesting and important work is done by Triana. Let me briefly introduce how this happened. Around a year ago, there was a publication in Nature Communications, and it really blew me away. And so some of my colleagues who are in the Amsterdam University Medical Center were not working on ALD, but they instantly recognized the power of that publication. And I had a mission. My mission was to make sure that Triana, who could choose with whom she wanted to collaborate and on which protein and disease she wanted to spend the next years. And my mission was to make sure that she will be focused on spending her energy and technique and anything on ALD. And we were lucky because the time I connected with Triana, we had 10 days left before the deadline of the ELA grants. And so we made it happen. We worked, we really had a clear plan. So, and if you really have a strong plan and a strong rationale, it doesn't have to take too much time to write a good grant. The grants for ELA are very competitive, and I think there were like 30-something grants last year. Luckily, we made it until the grants that were rewarded by the scientific committee. So again, a very deep thank you to ELA for allowing us to spend the next few years on this work. And I'm really excited to present here and to basically lay the ground floor, lay the work, introduce Triana. So I have a few slides on ALD and newborn screening, and then I'll give the floor to Triana. So we're going to talk about newborn screening, and newborn screening is important because we can capture the boys with ALD, but it will show in the next slides. We are currently in a situation where we do not know if all the boys that are picked up by ALD newborn screening really do have ALD. So there's really work to be done there. Yeah. So brief introduction. ALD is a rare disease. It affects about 1 in 15,000 boys and girls. Even though it's a rare disease, that means that in Europe, every year 350 new patients are born. The disease is caused by genetic mutations in the ABCD1 gene. It's a gene that's located on the X chromosome. So there's a difference in the way men and females are affected. The effect of this mutation is that there is a buildup of very long-chain fatty acids, and these fatty acids are seen throughout the body, but they mainly affect the brain and the spinal cord, so the central nervous system, and the endocrine organs, the adrenal cortex, and the testes. So in principle, it's a fairly simple disease because there's one gene and there's one effect. So we have the ABCD1 gene. There are mutations in there that are pathogenic, disease-causing, and this results in a very long chain fatty acid accumulation. But the outcome of an individual we cannot predict. So we can pick up boys at birth, but we cannot predict whether a boy develops one of these three outcomes. So boys or men can develop adrenal insufficiency or adrenal disease, and that can start already at the age of 6 years, but also later, as I will show in the next slide. Boys are also at risk of developing a leukodystrophy in the brain, and that can start after the age of 3 years. And in adulthood, both men and women will get a spinal cord disease, which is slowly progressive, and it starts in adulthood. And as I said, these core syndromes of ALD, the adrenal insufficiency, the cerebral ALD, and the spinal cord disease can start at different ages. And it's shown here. Here we see the age at which patients have one of these three symptoms and the percentage of patients affected. And we see here that the spinal cord disease starts in adulthood, and that the adrenal insufficiency and the cerebral ALD starts in childhood. And if we now zoom in to the first 10 years of life, and then we look at these numbers, we see that 1 out of 2 boys will develop adrenal disease, and 1 out of 3 boys will develop a brain disease. And these two forms of ALD are treatable. Adrenal disease with hormone replacement therapy, and brain disease with bone marrow transplant or gene therapy. But this gene therapy or bone marrow transplant is only effective when it started before the neurological signs and symptoms are visible. So really before the disease starts. So in the ideal situation, you diagnose ALD at birth. And if you pick up the patients, you can follow them up and monitor them for the endocrine function and the brain involvement. And as soon as it's necessary, you can start, treatment can be initiated. It was already recognized in 2004 by Professor Hugo Moser, who at an ALD at a newborn screening meeting in the United States said that ALD newborn screening saves lives. Well, most people agreed, but at that time it was not possible to diagnose babies at birth, because you need to have an assay in which you can analyze 100 samples a day. And the method that we had at that time was not quick enough. It took about 2 days, and you could do 20 samples. So this changed in 2007 when the group of Hugo Moser identified C26 lysophosphatidyl-choline, or C26-lyso-PC. It is a complex lipid that also has a very long chain fatty acids, a C26 molecule. And it's highly elevated in newborn Hupric blood. And the nice thing about the C26-lyso-PC is that you can measure it with mass spectrometry, and that is a high throughput assay. So at that time, from that point on, it was possible to run hundreds of samples per day. But it took several years for ALD to enter the newborn screening program, and that is the work from Élise Yazbeck. She lost her son Aiden Segan because Aiden was diagnosed too late. He could not be treated anymore. And she made it his life work to get as many states in the United States to start ALD newborn screening. And in 2013, New York State was the first to start newborn screening for ALD. And Joe Orsini, the head of the lab, the newborn screening lab in New York, made this happen. So this is the current situation in the United States. Almost all states are screening for ALD. That means that 97% of the newborns are screened for ALD. But outside the United States, in 2016, Taiwan started ALD newborn screening, and in 2021, regional pilots started in Israel, Italy, Japan, and the Netherlands. In 2022, a regional pilot started in Spain, and a year and a half ago, in 2023, following a successful pilot, this pilot that we did in 2021, the Netherlands started nationwide newborn screening for ALD. And it's expected that Australia will start this year or next year with newborn screening. So this is the situation in Europe. The Netherlands has started screening. There are pilots in Italy and Spain. We don't know how this will evolve when decisions will be made to start nationwide screening. And of course, we have a lot of experience. So we're helping patient organizations in England, in Spain, in Switzerland, and physicians in Germany, and researchers in Hungary to to move forward. And every country has a different process, so the only thing we can do is help with samples and knowledge. But as I said, we cannot predict the outcome. So all the boys that are picked up by newborn screening, they enter a long-term follow-up protocol, and that involves from the age of a year and a half or two, every 6 months an MRI to look at the brain, and from the age of a few months, every 6 months a blood draw to test for the adrenal function. And this is, of course, this is really, really difficult because we cannot, it is very stressful for the families because the outcome is every time is unknown. So it would be really nice if you could predict that. So that's another story that we work on. But what also became clear, so not every change in a protein, so when a building block is changed, causes a disease. It can also have a harmless function, or it can also have a positive function. And there's a way to classify genetic changes, and it's called class 1 to class 5, and with class 1 and 2 benign, so it's not disease causing, class 4 and 5 pathogenic, so it's disease causing. But this class 3, that's a tricky part, because that is a variant of uncertain significance. That means that a genetic change is found, a change in the protein, but we have no idea whether it's benign or disease causing. And there are these databases, for example, ClinVar, in which a lot of these variants are deposited. And when we just look at the number of these class 1 to 5, and we follow that with the expansion of the newborn screening in the United States, which meant that a lot of new tests were done, we see that there is a sharp increase in the number of these unknowns, these VUSs. So in this database, as of yesterday, there are 629 changes in the protein. So it means that one out of the 745 building blocks of the protein is changed, and we do not know if it's disease causing. But the effect is that all these children are undergoing this follow-up protocol. So following newborn screening, when a variant is found that we know it's disease causing, it's really clear, because this is the disease causing, so the boy needs to go in the follow-up protocol, will receive an MRI and blood draws to assess the brain function and the adrenal function. But what about all these boys and all these families that are now faced with a variant of uncertain significance? There's a chance that they have ALD, but there's also still a chance that they do not have ALD. So this is called a false positive. But as if we cannot demonstrate if this is a disease-causing or a non-disease-causing variant, it still means that boys will go in the MRI and get blooders who do not need that. So it's really important to focus on that. And that's where Triana comes in, because that is what she showed last year in her paper. And I'll try to explain this on this one slide. So all the tests that we have now is the analysis of the variant chain fatty acids, or the measurement of the peroxisomal beta oxidation, so the variant chain fatty acid breakdown. These are indirect measurements, and they are not tests that test the function of the ALD protein. The ALD protein is like a door in the peroxisomal membrane, and through this door, these fatty acids need to go. And we have no way to measure if the DNA change or the change in the building block affects the door. Is the door open? Is it closed? Can it only open a little bit? We cannot do that. And so we need to be able to do that. And last year, Triana published a paper in which, and she will show it in the next slides, but I will just use one sentence to do that. She can make these fatty acids that they have light, and that you can follow these fatty acids. And with that, you can now directly look at the function of proteins. And she can do that for many proteins. But I wanted, and I think Ayla and all our colleagues wanted to have Triana try to get this to work for the ALD protein. And with that, we should be able to determine whether a change in the protein affects the functioning of the ABCD1 protein. And with that, I think I stop sharing, and I'll give the floor to Triana. Triana, can you take over, please?
Yes, I will start sharing. Hello, everyone. You should be able to see my slides now.
Yes.
So thank you all very much. I'm really grateful to be invited. Really thank you, Ella, for giving this opportunity to us to study this incredibly challenging and interesting question on how we actually improve the measurements and develop a functional assay to assess if ALD protein is pathogenic or maybe will not lead to a disease. So I will divide it into two parts. In the first, I will tell you about this challenge of developing the assay, and then I will show you how it works in patients' skin cells. All right, so about a year ago, Stephan contacted me with this incredibly interesting problem, a challenge. Can we measure the function of ALD protein directly? And so we all know that the problem, the issue, the pathology of the disease comes from accumulation of very long chain fatty acids. And they accumulate inside the cells, but outside of the compartment that we call peroxisome. This is a circle, the blue circle that you see here. And it happens because the protein, the ALD protein, which transports or transfers fatty acids from the outside to inside of peroxisomes, is simply dysfunctional due to a mutation, and that causes the disease. So we thought, how do we imagine establishing a functional assay that will measure the function of ALD? So the way we can do it is create a molecule that resembles very long chain fatty acids, but at the same time, it is possible to follow this molecule inside the cells. So it creates a couple of challenges. Challenge number one is you have to have a high resolution microscopy imaging capabilities. And this is an expertise of my lab. We do high resolution or super resolution cell biology of live cells, live human cells. And then another challenge is how do you follow the probes? Very long chain fatty acids themselves are, they do not emit light, so they will not be visible under a microscope. So we collaborated with chemists and decided to create a fluorescent probes that you can see here on top of very long chain fatty acids. And you can see that it resembles very long chain fatty acids. So for cells, they recognize it as fatty acids. But then it has this bulky component, the chemical structure on the left side. And this is simply a molecule that emits light. So it's a simple tracer that allows us to follow these fatty acids inside the cells. And then we can do it inside live human cells. And for that, we look deep inside the cells and look at these compartments called peroxisomes. So we use several different reference markers to be able to find these compartments. And in pink here, you can see the insides of the peroxisomes. So all these circles, the pink circles are peroxisomes. And then in yellow here are the membranes, because it's a membrane enclosed compartments. And so what's interesting, the ALD protein is positioned on this yellow part. So it's place where it lives in the cell and where it functions. And so on the top panel, we just have peroxisomes. There is no staining. And on the bottom panel, we add these fluorescent probes that will potentially measure the transport. And you can see how these probes are imported inside peroxisomal compartment because they colocalize with the inside marker, which is pink. All right. So this can happen under 5-10 minutes, which is incredibly fast and allow us to actually quantify and measure precisely how this process is happening. So that's how we would imagine the functional assay to work. And that's exactly what we developed with the help of two brilliant chemists, Milena and Luc, at the Swiss Federal Institute of Technology. So we call these fluorescent probes that I just described to you PeroxiSpy. And this probe allows to do many different things. It can allow you to look at the peroxisomes inside living human cells and measure precisely what's happening, how much of the probe is imported inside of the peroxisomes. But what's most important, it's actually a direct measurement of transport of very long chain fatty acids from the outside to the inside of peroxisomes, which is in fact an ALD function. And so we decided to try to look at it with more precision, because the idea is to establish an assay where we can quantify certain parameters which allow us to distinguish between different variants of ALD. And to do that, we can do live cell imaging. Here you are looking at monolayer of human cells. So this is simply human cells. The white circles are where cells store DNA, the nuclei. And then at the beginning, there is no probe, and we are adding these probes, the fluorescent probes that I described, to the cells. And you can see, probably appreciate from this movie, how over time, you have accumulation of this probe inside this many different little blue dots. So every single one of them is a peroxisomal compartment, and every single one of them will contain ALD protein or ABCD1 protein on it, and will help impart these probes inside peroxisomes. But then how can we actually measure them to put a number on this process? So to do that, we do something a little bit more complex, which is we put a reference marker on peroxisomes. So here you have two cells. Three images on the left-hand side are control cells. We have a permanent marker of peroxisomes in blue, and then we are not adding any fluorescent molecules to the pink panel, and then the merged panels. And you can see this graph, there is nothing changes inside the peroxisomal compartments. But then on the right-hand side, we are adding the probe in pink here. And you can see how over time it starts accumulating inside the peroxisomal compartments. And now we can, on every dot in this graph, we can actually precisely measure, actually averaging hundreds of peroxisomes between different cells. We can measure how very long chain fatty acids accumulate inside peroxisomes in live human cells. So that would be, there are a lot of challenges ahead, but that would be a starting point for an assay. So we decided to check how would it work inside patient cells. We can obtain patient cells from skin. We call them fibroblasts, and we can repeat the same assay. So I wanted to share with you the data that we have so far. Here you're looking at two different cells. One is control with a matched healthy individual, and one from ALD patient with a pathological mutation. You can see here that we have a reference marker for peroxisomes in order to quantify where the probes will appear. And then we treat the cells for 10 minutes with the probes, with the fluorescent probes that we call peroxispy. And then you can see that after 10 minutes, peroxisomes have the probes inside them in the control panels, three top panels. And this is quantified in the blue graph. You can see the accumulation of the probes over time inside peroxisomal compartments. And then if we do the same exact assay in ALD patient fibroblasts or skin cells, you can see that the probes to a certain extent still accumulate inside peroxisomes, but there is a significant decrease in the accumulation, both in the rate and the absolute accumulation of, which we measure by fluorescent intensity of these probes that we created. And so each point here represents the averaging of many different peroxisomes inside the cells. And you can see that at any point, whether it's 5 minutes or 10 minutes, there is a significant decrease in this accumulation, which tells us that the function of this protein is compromised. So there's either a significant dysfunction or there's significant decrease in positioning of the protein on the organelle. So this assay hopefully will allow us to distinguish between different variants of ALD protein. And the final thing that I wanted to show you is that this assay, surprisingly to us, actually recapitulates some of the basic things of the pathology that we know about ALD. So that's what we started with, right? The accumulation of very long chain fatty acids outside of the peroxisomal compartment, but inside the cells. So the probes that we created actually resemble very long chain fatty acids. And if we incubate the patient cell lines for longer periods of time, and by longer, I mean 30 minutes, you can see and probably appreciate from the right-hand side image that there is an accumulation of the probe inside the ALD patient cells, and there is not so much accumulation, and every dot here is actually peroxisomes. And the reason for it is because in the healthy cell line, peroxisomes are capable of importing very long chain fatty acid and destroying them by oxidation. All right, so thank you all very much. I really hope you can appreciate that there is a possibility of direct measurement, and hopefully we will improve the distinction between the different variants of ALD. I would like to thank Stephan Kemp for this incredible collaboration opportunity, Ella for giving us the opportunity to actually do the work, and all the people who participated in it, including chemists who synthesized the probes for us. Thank you all very much.
Triana, can I add one sentence?
Absolutely.
Because now people may think that, whoa, we're done, but these are the first probes. So this is the first essay. So you see that the difference between controls. The reason I'm saying it because I have to leave in 2 minutes, and I want to make this point. So the difference between ALD and controls now is not that large. It's like 20%. But these were your first probes. So these are actually the probes that are not yet ALD specific. So that's what, yeah. So that's really important because otherwise people may think, oh, you're done. This is our starting point.
A lot of challenges ahead. We are just starting. Yeah.
We know that the technique works.
Fantastic. I love the joint presentation. Thanks so much, Triana. And I hope to hear many more talks from you. And Stephan, gratitude that you bring her into this field, much needed. So
I'm sorry I have to leave.
No worries.
Thank you all, and we will be back.
I'm sure you
have a great meeting.
Take care.
Bye.
Good. Great. I'm going to talk next about progress in precision medicine for ALD. What is next? Along the themes that while we are making progress, there are still many challenges ahead, as Stephan said. I think that is very much true for genetic therapies today as well. And I will outline some of the progress we've made and also how we think about the current challenges and what may lie ahead. So just briefly, disclosures around various different gene therapy trials I run and companies I've formed. You've already heard from Stephan about the ABCD1 gene and its role in adrenoleukodystrophy, but just to remind us that there are different phenotypes. On the one hand, there is childhood cerebral ALD, and on the other hand, adrenomyeloneuropathy. One of the big challenges is that we currently do not have markers at birth that will help predict what phenotype will arise and how patients will be affected. Will their brains be affected? Will their spinal cords be affected? And hence the work that Triana mentioned is much needed in defining the nature of different mutations. I think we will still be left with intense need for monitoring over time and understanding other environmental factors that also contribute to the phenotype evolution. Just to briefly outline the deep differences in phenotypes due to distinct pathology. You're born with a gene defect, you have elevations in very long chain fatty acids that give rise to newborn screening, as described earlier. Between the ages of 5 and 10, you have this about 30 to 40% risk of developing cerebral ALD. You go on into adulthood, and then the predominant phenotype becomes that of adrenomyeloneuropathy, a spinal cord disease, but adults still are at risk for developing cerebral ALD, and you'll hear later on about biomarkers, and I'm looking forward to Fanny Mochel speaking about this in more detail. So I think it's important to remember that the pathology is quite different for the brain, where we have spreading lesions, as many families sadly know, that move outward from the center of the brain and spread into the central and subcortical white matter. Different for AMN, where you often will have the spinal cords affected, particularly those that carry motor signals down to the muscles, as well as the sensory tracts that bring sensory information from the periphery up to the brain. And while AMN is a spinal cord disease, you can sometimes see spinal cord and cortical spinal tract involvement in brain. As I mentioned before, what is challenging in adults, there can be an overlap of these two occurring in adulthood. And 1% of women, we think, also develop brain demyelination, and we're currently trying to understand whether that is due to skewing towards the defective X chromosome. So I will briefly outline precision medicine for ALD and talk a little bit about the modalities that are in use. This ranges from AAV-based in vivo gene therapy, which is direct delivery of the gene through a virus carrying it, direct delivery into a target organ, whether it be the intraspinal fluid, the bloodstream, or the brain. Then ex vivo gene therapy. This is usually done by harvesting cells from the bone marrow. These cells are then transfected outside of the body with a virus, usually a lentivirus, that then carries a healthy copy of that gene. And these cells are then re-injected into the patient's bloodstream. And then lastly, there are some first emerging trials in leukodystrophies using antisense oligonucleotides, but I will talk less about that. So how is gene therapy performed? We know that boys who have cerebral disease usually start with lesions in the white matter of the brain. We do not start treating them until they have contrast enhancement. That is a sign of the blood-brain barrier breaking down. It is also a sign of the disease entering an active inflammatory phase. And when we see boys in that phase, we bring them in, mobilize their peripheral bone marrow cells, harvest them, select out certain types of cells called the CD34 positive cells. We transduce them with a lentiviral vector, delivering a healthy copy of the gene, deliver them back to the boys into their bloodstream after some chemotherapy, either busulfan and cyclophosphamide or busulfan and fludarabine. These cells then move from bone marrow to blood and from blood to brain, and there become microglia-like cells. We follow these boys for a 2-year period. This is very similar to conventional bone marrow transplantation, with the difference that these are cells from the boys themselves. So these are autologous cells. Hence, we avoid problems with engraftment and graft versus host disease. And this led to a first FDA approval for gene therapy of a leukodystrophy in the US in 2022. Despite the progress and our ability to do this in 67 patients in the trial, and since then in the commercial space in about a dozen children, there are challenges, and this has been also reported in the New England Journal last week in the form of hematologic cancers that arise after gene therapy for adrenoleukodystrophy. And these are mostly hematologic cancers that affect the blood cell development and cause abnormal blood cells, requiring often a second bone marrow transplantation. So just to highlight here briefly the progress and the thinking behind ex vivo lentiviral gene therapy for cerebral ALD, because there's microglial cell loss at the leading edge of the lesion, as well as an open blood-brain barrier. This allows for gene delivery through hematopoietic stem cells. More than 70 patients with childhood cerebral ALD have been treated with ex vivo lentiviral gene therapy to date. Most patients, 94%, have achieved stable neurologic function without major functional disability. But safety events are important, and they relate not only to mobilization and conditioning that we knew of before, but more recently we have recognized that myelodysplastic syndrome and other forms of hematologic cancer are associated with a lentiviral vector and insertional mutagenesis. We don't understand this currently well enough. Here, the first 7 patients reported in the paper last year. Note that all of these patients did not have a well-matched sibling donor and no other good unrelated donor options when they came into the trial. So still here, I think the risk-benefit had been initially in favor, but as we learn more, we are probing this more thoroughly. I think the important thing to highlight that the majority of these children have received fludarabine, the less myeloablative chemotherapy, compared to the cyclophosphamide therapy that we used in our first trial. However, it's important to note that we do not understand all factors contributing here. And sadly, since we've reported these first 7 patients last year, there have been an additional 3 boys who've developed hematologic cancer. So we expect that in future there will be more cases. And just to highlight how this occurs, we're using lentiviral vector to deliver the gene under the influence of a promoter, and we're not only hitting the one place of ABCD1 where the gene is inserted, but it can have thousands of integration sites, and hence the question of whether the inserted genes can influence the activity of genes near them, and that may sometimes result in no change function, decreased amount, or uncontrolled growth. And so we are still trying to understand all the factors where insertional mutagenesis may contribute to the development of cancer. There have been many trials using these different vectors, and the promoter was originally used because that was what was used successfully in the first boys treated in Paris, but it might be that the promoter is too strong. It might also be that we need the stronger chemotherapy of the first trial. It might also be that the amount of expression is too high, and there might also be disease-specific factors. So there's still a lot of work here to be done. But in the interim, for families, I think it's important to remember that multiple considerations must be balanced. We know that for gene therapy, there is now a risk for hematologic malignancy, but we can avoid graft versus host disease. We can avoid engraftment problems. There's shorter hospitalization and post-care. It may take longer to treat, and there might be higher upfront costs of therapy. On the other hand, for allogeneic conventional bone marrow transplantation, graft versus host disease risk remains, graft failure risk is greater, and all of that needs to be held in balance as you are making decisions. And so we do not currently treat any boys with well-matched sibling donors, and we will use well-matched unrelated donors as well. But for those populations that are lacking matched sibling donors, and they're often African-American ethnicities as well as others, that it is important to have options such as gene therapy. Nevertheless, we are working to move forward to optimize lentiviral vector design. We're thinking about alternative promoters. We're working with here David Williams to optimize vector design for childhood cerebral ALD. We're also working on new gene editing approaches for ABCD1 to enable precise editing and use the endogenous promoter of the patient themselves. So a lot of progress here and work to come. So just to remind you that beyond child with cerebral ALD, there's also AMN, and there is a different gene therapy approach that is being used for that. It's called in vivo AAV gene therapy. So we're using a different kind of virus that we've packaged the ABCD1 gene into, and this is being delivered in the ABCD1 knockout mouse and looked at in culture. It's also been studied in the ABCD1, ABCD2 double knockout mouse, and we're showing that we can lower very long chain fatty acids in both of those models and have shown improved grip strength here also with this double knockout of ABCD1, ABCD2. And just to highlight a lot of the work that has also been done in non-human primates to optimize delivery through the intrathecal space to get the correct gene delivered. And this is now led to a first trial that is enrolling at UMass Worcester in Massachusetts, as well as the Amsterdam Medical Center. So a trial led by Larry Hayward and Mark Engelin. So to highlight that women for many years have been excluded from trials because they were thought to be carriers only. We now recognize that they are actually equally affected and experience particularly the spinal cord and peripheral nerve problems. And as you all know, men have one X and one Y, while women have two X's. And so the fact that they had a second X was thought to protect them from the disease. Well, it turns out that that they are that one in all women, one X is inactivated, and sometimes this inactivated X is the healthy one, and that skewing of this process can contribute to pathology and the neurology here. And so we're actively working with Jenny Lee, who is an expert in X inactivation, to understand how to achieve partial reactivation of the inactivated X chromosome to maybe restore ABCD1 expression in a physiologic manner. And so this is a very nice paradigm to achieve genetic correction at physiologic levels. So just to highlight briefly, skewed X inactivation in women influences very long chain fatty acids, and we also think the neurological disease severity. You can see here that depending on the level of skewing, you can see different levels of ABCD1 expression, and that the levels in women can vary widely depending on the amount of skewing they have. This can be measured in peripheral blood, and some women who have skewed completely to the mutant X can have levels of very long chain fatty acids as high as the males. There are also women who are completely skewed to the healthy X, and they have completely normal levels and seem to be doing better, but it is still early days. In order to understand this better, we've created a mouse where we've been able to inactivate the healthy X on an ABCD1 knockout background, and we can show here that these female mice have very long chain fatty acids as high as the male mice. So it is a nice opportunity here now to start studying this process. Do other genes influence how ALD manifests? I think it's going to be a new era of us thinking of other genes here beyond ABCD1 in precision medicine. We know that the very long chain fatty acid elongation is controlled by an elongase called EOVL1, and that one contributes here to the very long chain fatty acid formation, so everything above C20 and C22. And likewise, when we create saturated very long chain fatty acids, we have to think about other genes such as SCD1. So just to summarize, first FDA approval for adrenoleukodystrophy ex vivo gene therapy has arrived, but we are seeing, even in this commercial space, emerging risks that need to be weighed against efficacy. We need to improve vector design, and gene editing is also a new modality currently underway. In vivo gene therapy has led to a first trial in AMN being conducted in the US as well as in Europe. Skewed exon activation can modulate disease, and we think that this might be of importance to women and give rise to new therapeutic targets. More genes in the lipid pathway can be targets of therapy, and I'm looking forward to more innovative therapies coming about. Precision is not only necessary around the genes and the cellular targets, but also around the symptoms. And this can also lead to new trials, and hope some of the work that has been funded by ELA for the collaboration between MGH and Amsterdam in treating leg discomfort in women with ALD will lead to new trials over time. It has allowed us to really conduct here a first trial targeting leg discomfort in women, but we are in the final stages of analyzing the data. We'll hope to present that shortly, but it's also important to recognize that all of these attempts lead to new trials over time, and we've really understood here an array of different symptoms that can be very precisely targeted for women with ALD. So I think much progress, and look forward to questions in the discussion. So I think it is now my pleasure to introduce the next speaker, who comes to us from Paris. This is Élise Yazbeck from the Bicêtre Hospital and Pitié-Salpêtrière Hospital, and she has worked for the Reference Center for Leukodystrophies, also with a very esteemed colleague, Caroline Sevin, and she will present on the pediatric management of ALD patients and the 2-year results of the Nexus study. Élise, I'm delighted that you're able to join, and look forward to your presentation.
Yes. Can you see my screen and hear me?
Yes.
Okay. Hello, everyone. I'm very happy and pleased to be here, and thank you, Ella, for inviting me. I will talk to you today about the pediatric management of ALD patients and the 2-year results of the Nexus study for the minor X treatment. So now you already know that the child cerebral ALD is a form of ALD that is due to mutation in ABCD1 gene and a defect in the production or function of this protein that is laying here, creating a lack of degradation of the very long chain fatty acids, VLCFAs, in the peroxisome that are the disease marker we use in biochemistry. So they accumulate mostly in adrenal glands and nervous system, creating neuroinflammation, which is the leukodystrophy, but also axonal degeneration, oxidative stress, and abnormal energy metabolism. So we have mainly in clinics 4 circumstances of diagnosis. The first is the cerebral form, mainly in childhood. The second is the AMN with the spastic paraparesia, myelopathy, and neuropathy in 100% of men and most of the heterozygous women. And 10 to 50% of them will finally also develop a cerebral form. Third, some are diagnosed with isolated adrenal insufficiency, which become at the end much more frequent. And fourth, some are diagnosed at the pre-symptomatic phase. So the natural history shows us that all along childhood then adulthood, the risk of cerebral form is higher than 60%. That's why we need exhaustive family study. And that's why the future is the neonatal screening, because as you already heard today, we lack of a marker to differentiate these phenotypes and predict which form we will have in our patient. We have no genotype-phenotype correlation and along with more than 700 mutations. The CCLD is a very aggressive and neurodegenerative disease when it's not treated. It begins in childhood and mainly with a regression in the school performances of the boy, behavior problems, and it may be misdiagnosed as an ADHD. And then the evolution over 1 to 2 years leads to a destruction of the whole brain with diffuse lesion in the white matter, causing major functional disability that I will call MFD, and a loss of all the neurological capacity of the little boy. But this CCLD is treatable leukodystrophy, as we said, by hematopoietic stem cell transplant or gene therapy. And I will also talk to you about a new molecule that is leriglitazone. But we need for early detection of these lesions for the treatments to be effective. And when I say early detection, it means that there is almost not any neurological function score. I will call it NFS. It has to be of 0 or 1, and very small lesions on the MRI with a radiological loss score less than 10, and already signs of inflammation with the gadolinium enhancement. But we know that unfortunately, most often the brain disease is diagnosed too late nowadays. I will not talk much about HSCT and gene therapy, but now you know that the allo-HSCT can provide a correction of the brain immune system, that is microglia, so has a direct effect on the neuroinflammation, needs a reset of the peripheral immune system, it needs myeloablation and immunosuppression, but always remember that there's a delay for the onset of the action of this treatment that is from 6 to 12 months. Gene therapy is an auto-transplantation of genetically modified hematopoietic stem cells, so no need for donor search. Still need for myeloablation, but no immunosuppression, and the same effect with, as we heard, the risk of hematologic cancers. So as I said, the treatments can stop the cerebral form when it's performed early and always with few months of action delay. So now how do we follow up the boys in pediatrics? First, with brain MRIs that we have to perform beginning from 2 years of age, every 6 months till adolescence, and then every year till the adulthood if there is no problem, because we're seeking for this small demyelination lesion that becomes inflammatory and can access to CLD treatments that we now know. Second, we follow up the adrenal tests every 3 to 6 months to offer the hormonal treatment. And third, we follow up the AMN signs for the symptomatic treatment and maybe in the future for the local gene therapy or leriglitazone. I will give you some basics about the natural history of the disease to then explain the effect of the treatment. First, the natural history, clinical-wise, in childhood. It was described by the team of Dr. Stephan in France on a registry of 52 patients identified with CCLD for a 10-year study period, with 47 of them with more than 1 year of follow-up. The median age was 7 years. 62% of them did not undergo HSCT, and 38% of them had HSCT. As we can see, the main symptoms were not seen in the patients treated with HSCT, unless one case with some cognitive symptoms, and mainly only adrenal insufficiency. As for the MFDs I talked to you about, most of them did not have MFDs, but 3 patients had cortical blindness after HSCT, whereas the ones who weren't treated had much more MFDs. So once again, we see how it's important to make an early diagnosis to be able to treat these patients with HSCT and have a good outcome. And the MFD-free survival curves shows it. The natural history clinical-wise was also described by Raymond et al., showing that after 6 months of diagnosis, we have typically a rapid decline on the clinical NFS score, whereas with HSCT, this decline is halted or slowed. And in the end, We had a description of the imaging and natural history by the team of Professor Malak on a mixed retrospective and prospective cohort that was diagnosed early with the disease with a clinical score of 0, so pre-symptomatic boys, and no evidence at the beginning of GAD enhancement. He excluded the patients more than 13 years, the patients with no change in loss score for more than 6 months, and the ones diagnosed with arrested disease. The results showed a median age of 6.5 years. By 6 months, 50% of the boys had become GAD positive, and by 18 months, 80% of them became GAD positive. And of course, low score is the gold standard clinically wise to read an MRI of CCLD, but to improve the technology, he developed the assessment of the volume of the lesion to understand what the rate of the growth is and to describe this fold change in the lesion volume across time in CCLD patients that are not treated. And we see in blue the curves of the patient that have a naturally arrested disease. So now that you know all the bases, I can talk more about this molecule, leriglitazone, that is called Minorix. It is a metabolite of the pioglitazone, a PPAR gamma agonist that has, though, an immediate action on peroxisomal receptor, and that is interesting on 2 points of view. The first, it has a good intracerebral penetration, and the second, it has an anti-inflammatory effect in the brain. It's very easy to give. It's an oral administration as a syrup. It's very well tolerated in children. So the Nexus study, which began in 2020 and closed in 2022, is an open label design study with a population of boys aged from 2 to 12 years who had some non-enhancing GAD negative lesions on the MRI, and for some GAD enhancing, so GAD positive brain lesions. All of them had the same criteria as an HSCT, so low score less than 10, and they were pre-symptomatic or post-symptomatic, so NFS 0 or 1 for the clinical examination. 23 patients were enrolled in 4 countries, and 20 were evaluable at 2 checkpoints, 6 months and 2 years. And the main endpoint, the first endpoint, was to observe an arrested disease or lesion growth deceleration without a clinical progression. There were also secondary and exploratory endpoints with low score, clinical NFS, lesion volume, and some plasma biomarkers as neurofilament. And the first checkpoint at 6 months is now completed, long time ago. And we know that 95% of the boys showed disease arrest or a lesion deceleration. All of them had no clinical progression within the first period of 6 months, and 40% of them showed an arrested disease. Now we have the checkpoint at 2 years, which is not already published, but we have the press release lately that confirmed that leriglitazone has met the primary endpoint in Nexus. It is a real significant difference in arrested disease with leriglitazone treated patients when we compare them to the natural history of the disease that I just explained to you. So now a submission of European Marketing Authorization application is ongoing, and we expect it for mid-2025. Just few slides to tell more details at the checkpoint of 6 months. For the clinical NFS score, you see that leriglitazone was comparable to HSCT and much better than the natural history evolution. Same for the loss score. Under leriglitazone, the evolution was comparable only in the 6 first months, comparable to a gene therapy or an HSCT. And the most interesting is maybe the lesion volume, the lesion growth. because here in gray you can see the curve of the natural history fold change lesion growth, whereas in colored lines you can see the patients, and it showed at 6 months that this lesion growth is below natural history with leriglitazone. It was also the case for some biomarkers and especially the plasma neurofilament. So, last point in leriglitazone, you must know that several patients that we enrolled were eligible, in fact, for an HSCT. But we gave them leriglitazone knowing that the lesion growth will most probably be stabilized while we seek for a donor. And among these 20 boys, 8 of them underwent an HSCT and went out of the study during the first 6 months. So to conclude about Nexus, it's a safe treatment for the boys. It is well tolerated with almost no adverse event and sometimes some weight increase in the first month. We enrolled 23 patients and analyzed 20 of them. The data showed clearly a slowing down of the lesion growth if we compare it to natural history. And it was confirmed at week 96, so at the 2 years point, even if we know that minor X is not the equivalent of an HSCT and not a gene therapy. But of course, it helps. My last 2 slides are just to share a French experience. Now that since 2022, we cannot give leriglitazone in Nexus study because it is closed, we decided along with the French health authorities to give it as a compassionate use in patients that might need it. And it's also available in some European countries. And we could give it this way to 30 boys that we enrolled in France, among whom 22 were analyzed by the end of 2024. And we divided our patient into symptomatic and asymptomatic patients. So the symptomatic ones have advanced CCLD. They're not even eligible for HSCT, but we want them to have a low score less than 16 to enroll them. As for the asymptomatic patients we saw, they had early CCLD, but not yet eligible for HSCT because GAD negative, or already eligible, but they don't have any compatible donor. So I focused on the symptomatic patient. 13 out of 22 of our patients were symptomatic, and among them, 5 were considered as responders. And we noticed that these 5 were above 12 years of age at baseline, and most of them had relatively mild symptoms when we saw him for the first time. The 6 others were non-responders with a rapid deterioration of the disease and at least a major functional disability at 3 months of treatment. And we noticed that most of them were younger, less than 12 years old, and they had, most of them, motor symptoms or almost cortical blindness when we first saw them. So now we know that when we want to give compassionate use leriglitazone for a symptomatic boy, if this boy is younger than 12 years with a high loose score but still under 15, with already motor symptoms or cortical blindness, this is likely a pejorative factor that will make this treatment work less in these patients. And at the end, I just want to tell you that a phase 3 trial is ongoing in adults, so men with C-ALD, called CALIX, in 4 sites in Paris with Professor Mochel, in London, in Leipzig, and in Madrid, comparing leriglitazone to placebo in adult C-ALD patients with a first step of 18 months dosing, hoping that all patients could cross over to leriglitazone if the efficacy is proven at the first analysis. But if primary endpoint is not met, the trial will continue to the next analysis point at each time. Thanks a lot, everyone.
Terrific, Élise. Élise, could I just use my moderator privilege to ask you a quick question? When you compare, you showed that slide where the HSCT and the gene therapy less scores are shown. Could you show that again?
Yes, I think I have to share again. Excuse me.
And I might have missed this. My apologies, Élise. But are you comparing here the next one, I think, where are these all patients who are gadolinium positive?
No.
No. So all of the patients in the gene therapy and the HSCT were gadolinium positive.
Yes.
So you're comparing apples and oranges then, right?
Yes, right.
Okay. Just point that out because it changes the data, right?
Yes, right.
I think it's so important to get this drug to patients, but I worry a little bit if we're comparing differently, right? So
of course. So yes, to point out, with leriglitazone, we have two kinds of patients, GAD positive and GAD negative, of course.
Okay, great. Thank you for clarifying that, Élise. Very important work. Yeah. And now it is my pleasure to introduce colleague and friend, Professor Fanny Mochel, who has done so much for the field in metabolic diseases, and seeing her at SSIEM regularly always reminds me of the much larger scope of her activities. She comes to us from the Sorbonne University and Paris Brain Institute, Leukodystrophy Reference Center. So she'll provide an update on biomarker studies in men and women with X-ALD. Thanks, Fanny, for being here.
Thank you very much, Florian, and for the kind introduction. Good afternoon or good morning, everyone. Thank you for the invitation. So I will bridge with the presentation from Élise, whom I had the chance to work with for a couple of years, and definitely focus more of this topic on biomarkers and why we need them. But again, just to make a bridge with the previous presentation, and here are my disclosures. I wanted to say just a few words about what Élise finished up with, talking about leriglitazone in adult men with cerebral ALD because of what is at stake at the moment with an ongoing phase 3 trial. Just wanted to tell you, you may have been there last year. We presented the data that we had on 13 patients treated with leriglitazone in this compassionate program that Élise referred to. So if you are interested, we have a website, which is now also in English, where you can find a summary video of the data and of course the paper published in Brain last year. And so we reported on 13 patients. Now we have more follow-up, obviously, and 10 out of 13 with really great results. We have treated since then 7 new patients with up to a year and a half follow-up, and in 4 of them the same pattern. The patients who do not respond are patients from 60 years of age, or unfortunately, of course, also not candidate for transplant, or patients with dementia or prominent cognitive alterations. But in all of the patients, we have seen great data. Amazingly, actually, for I must say, in terms even of impact on the cortical spinal lesions, which are the most life-threatening, with even a decrease of those lesions, which is not just related to edema. We are looking into this with a lot of imaging modalities at the moment, including tensor imaging. I will explain a bit. But unfortunately, we were not granted a conditional approval by the EMA. And so the CALIX study that Élise mentioned, which is a phase 3 study versus placebo, is now open in Europe in the sites that Élise mentioned, including one in Paris. I'm saying that it's heartbreaking for us because we have to now enter patients in a trial where we have a placebo where, and this is my standpoint, but I stand for it, and I'm happy to answer questions about it. I don't think it's very much ethical at this stage, but we don't have a choice. And we still, obviously, it's still an access to the drug that we have. So if you know of patients with cerebral ALD and GAD positive lesions, we cannot enroll patients with GAD negative, even if we know that some of them will die, and we've seen that with GAD negative lesions. But if you know of patients who are not candidate for transplant because of age factors or no donor, or because they just don't want to go to transplant, please contact one of the site. And because this is the study isn't going this year, but we're sort of running with time to try to enroll the patient in the US and in Europe. So please do not hesitate if you have questions on that. So I, again, today was going mostly to discuss further about the biomarker aspect because, and I'm going to start focusing on the myeloneuropathy, and it was actually very nice to have Florian's talk on the development of therapies there. And we'll understand later what is critical actually to have markers to evaluate efficacy, because it's one thing to have a drug, it's one other thing that it is safe. The third part is how do you evaluate it? And sometimes we know of trials that were not able to show efficacy because of not the right primary outcome. It's the case for actually the Lier trial in men with myelopathy. The 6-minute walk test was negative, and because of that, the regulatory agencies denied access even for much more important indication like the cerebral ALD. So it's very critical to really find the right marker, obviously, to assess efficacy. And so for that, I'm going to start just presenting work published already a few years ago from, at the time, a PhD student who was brilliant, Isaac Adaniegou, who conducted this multi-parametric study. So basically different kind of parameters that we looked in the spine and the brain of men with AMN. And this is what you can find in the paper. This is the results. I'll get back to that. But this is just to illustrate the different type of methods that we use to basically trying to find markers sensitive to disease evolution and to treatment. So one of the things that we did with Isaac was first simple analysis of the volumetric of the spine with T2 images, where you do some segmentation and then you measure the cross-sectional area. And you can see here very broadly, I mean, the difference between control and patient with the atrophy that we have in patient. But this is not so sensitive to change, especially if you want to try to distinguish between the gray and the white component of the spine. And this is, of course, due to the demyelination in patients. You know, this butterfly that you see in control, you don't see it much in the patient. So Isaac has used some deep learning algorithm for that. But we also used another method, which is called magnetization transfer. And the concept is just that you use some radio frequency, basically that you apply on a tissue here on the spine in order to study the coupling between the macromolecule proton pool and how this change of energy is going to basically transfer from water to your tissue of interest, here the myelin content. And you basically compare with and without the radio frequency. And from that, you can derive basically some content of tissue, and here again on myelin. So we use these two methods, and we'll see that the magnetization transfer was the most sensitive one. But we also collaborated quite closely with the Center for Resonant Magnetic Research in Minneapolis with Pierre-Gilles Henry. So this is the center where actually brain magnets have been developed historically, now with very, very high fields. So it was a great collaboration, and Pierre-Gilles is one of the world leaders in spectroscopy, and he has now applied it to spine. And the reason why it's so difficult, spectroscopy is a very sensitive, but also very difficult technique to address because of all the methodological artifact that you may have. And motion is actually a big one. I mean, anyone who does an MRI knows that you should not move. This is true for any study, for volumetrics as well, but for spectroscopy, it's even more critical. And of course, the spine here is very much impacted by even breathing motion that, of course, we cannot stop. So Pierre-Gilles has developed tools to actually take into account these breathing patterns so that we can still extract the measurement of some metabolites. So basically small molecules that are going to be reflective of metabolic changes in the spine, not just the structure, but also how healthy the metabolism is, with different metabolites reflecting more of the neuronal component or the glia or the energy homeostasis. The other method that Isaac developed was based on diffusion tensor imaging, and basically the conventional DTI that most neurologists know about is based on what we call some tractography, where you, to put it in a simple way, you analyze the properties of water diffusion along fibers, and from that you can derive some aspects of fiber trophicity. But the problem you have with that is that with conventional MRI, DTI, you cannot separate crossing fibers. As you can see here, it's very blurry in a dedicated voxel. So the voxel is basically where we looked in a very local way at those properties. And so Isaac has applied one of the tools, because there are others, but this one, we find it very successful, what is called pixel-based analysis, where you basically, thanks to complicated methodological aspects I want to get into right now, but the idea is that you can analyze these individual fibers because you can actually distinguish how they cross and their orientation. And so from that, you can derive three metrics. One is the fiber density. One is the fiber cross-section, so basically how many fibers you have. Fiber density is how thick the fiber is, or a combination of both, which is called the FDC. And this method actually has been developed by colleagues at UCL in London, and we were one of the first to apply it to this rare disease field. Since then, there have been a lot of studies using it. So I'm going back to this data that, again, are a few years ago, what do you see here? I mean, you see all of the methods I've been mentioning, from DTI here, like the fiber density, or from just the cross-sectional measurement of the spine, or spectroscopy, or the magnetization transfer. And what we are looking here is what we call the effect size. So basically how much the method is sensitive to change. And why does it matter? Because if you look here at basically the number of subjects that you have to enroll to see an effect, so here you have like a 20% effect or 80% effect, basically depending on the effect size of the tool you are looking at, you are going to need more or less patients. And in the field of rare disease, it's very important to take into account that we are limited. Obviously, we cannot enroll thousands of patients with ALD. So if you have a drug which is already like a 40% efficacy, which is already pretty good, but if you have a marker with, like 0.5, for example, effect size, which is what we have a lot in the clinic in terms of, for example, clinical scores, well, then you are going to need this 1,000 patients or more. So we are really aiming at markers with really greater effect size so that we can reduce the number of patients per group. And here in the study, actually, the magnetization transfer ratio, the MTR, seemed to be the most sensitive to change. We also had very good results with the FBA and comparable one with spectroscopy. So now we are basically applying all this methods development to women, because as Florian mentioned, they've been so far, and I know there are great efforts in Germany, in the US, in the Netherlands in particular, for doing longitudinal studies in women to understand better aspects of pain in particular, but also, of course, other symptoms. And what we want to do, and this is with the support with Minorex, is to perform exactly the same analysis that we did in men with women. And so we are doing this multiparametric imaging exactly with the same methods I just presented. And we are combining that, of course, with some aspects of motor function, like the body sway that we know from the group of Mark Engelen. He's very sensitive to change in men, and now we know also in women. And we are also measuring some biomarkers, in particular the neurofilament that we know in ALD is also has potential, to show disease progression. So we are doing this in 3 time points. So all the patients right now have completed the baseline, and they're starting their first year evaluation. We enrolled 30 women and 10 controls. This is the team of clinical research assistant and doctor who supervised this study, and that some of you will recognize. And this is also a very nice collaboration with Emo Iska, who is a postdoc now in our team from the group of Mark Engelem, who is doing basically all this analysis that Isaac has set up as a pipeline. So I wanted still to say a word as well on not just the myeloneuropathy, how we can look at it in both men and women, but also on cerebral ALD. And for that, I just wanted to say, if I may, a little word to both presentations from Élise and Florian about percentages that are given about the frequency of cerebral ALD in adults. I know especially the graph that we always show where there is this peak in children and then there is a little bump in adults, sort of saying that we don't see that many patients with cerebral ALD in adulthood. Also saying that around 40 or 50 years of age, you don't see any more of cerebral form. We know now that this is incorrect, and I think those graphs should be redone. We don't have yet the frequency values, but in our experience, and I've been taking over, as you probably know, the great cohort of Patrick Aubourg and Caroline. In the adult, it's definitely more than half that we see over time. And we see patients at 60 years of age starting cerebral ALD without even symptoms of myelopathy. So we have to keep this in mind because we still see too many geneticists, neurologists who will not think about cerebral ALD in a patient with ABCD1 variant. And I really want to stress that because we can intervene and we have to look for it. And it's unfortunately much more common than we thought. So going back to diffusion tensor imaging, the data I presented to you were still generated in groups. So basically comparing patients and controls, or also patients treated over time. But what the BrainTail biotech has been developing is an individual analysis of the white matter. So basically, like an MRI, like a standard MRI that you can see in just one patient and see over time and measure, for example, progression of low score or gadolinium enhancement. This pipeline, which is a calibrated, standardized, and automated measurement of DTI, allows to look at individual maps of DTI. And this is extremely useful because then you can follow individually patients, and they have a CE approved for that use in the clinics already, so it's not just research. They are looking in 19 brain regions to measure those parameters of diffusion. And if we go to a topic that we are more familiar in cerebral ALD, which is transplant, apologize for the very small vignette here, but this is a patient that we transplanted at the early stage of GAD-positive lesion here of the occipital horn in his 20s. If you look, even if it's small, at just standard MRI, you see no change basically in the brain. But if you apply DTI, you see a lot of changes at 3 months that then tend to improve at 6, and this is the 1-year data, which is comparable, even better than what we had at baseline. So this is just to show the sensitivity to change, but also how we can look at that in just one patient. And so we have been applying that to the advanced study. Basically, this is still unpublished data, but just showing you, for example, for patients who were initially in the placebo group and who converted to after 2 years, it was all patients treated. We saw progression of DTI measures with different modalities, including this one. And then when you switch, you see basically an effect of the treatment. We have now different ways to look at the impact on lerglitazone on the brain, and this is one of them. We are also using this pipeline, and this is in the brain paper I mentioned, with Marianne Gulls, who has done a lot on the volumetric analysis of this patient. She's a PhD student in the group. So this is basically what you can see following patients under treatment with lerglitazone who are the good responders, basically 70% of them. And this is a patient who was 68 years of age when we started and unfortunately progressed despite the treatment. You can see also how we can follow the treatment effect. Now we are looking with another student, Luca, at the impact of transplant on different leukodystrophy, not just ALD, but also CSF1R related leukodystrophy. And this is only very preliminary data because it's just from last week, actually, but this is very interesting for us to see that we see definitely, especially in the course of the 3 months post-transplant. This is some of the diffusion marker, the medial diffusivity. You see some deterioration related, of course, to the fever, to a lot of things happening at that very complicated type of transplant. And then you see at 6 months changes in all the same direction. And then you see at 9 months something else. And we are wondering if this is not reflecting actually the big impact on this new microglia from the donor, making them some changes. And after that, we usually see that the parameters are back to the baseline, or of course we have longer follow-up that I didn't show here because I just wanted to focus on this 1 year, but with complete stabilization with transplant. So this is interesting ways now also to look better at what we do when we use this cellular therapy. We have currently as well an ongoing multicentric national project where we want to address the question whether this DTI measure, not just for treatment, can allow us to detect the cerebral ALD earlier, because as you know, the earlier we intervene, the better. And from the advanced cohort, and this is data not just from Paris, but also from Amsterdam, we were able to see that one of the index score derived from the DTI, basically that is called the RD index 19, showed really a significant change in the patients that in the advanced study converted to cerebral ALD, especially the ones on placebo, versus the non-converters. And so our hypothesis is that maybe this DTI measure can actually detect the cerebral form a year before standard MRI, which is just the Lowe's and gadolinium analysis. So for that, we are funded by the Ministry of Research with 100 men in 12 university centers in France. So it's also covering the majority of main centers in France following these patients. So this is exciting. And of course, this is enrollment has just started. So we'll be happy to share some data once we have, but this will take some years. This is, again, the modalities we are looking at into that study, comparing basically the Brentaine marker to standard. And we have a group of experts here who will blindly assess the conversion to cerebral ALD. We don't do only DTI. We're, of course, looking at standard neurofilaments, but we're also putting some efforts on neurocognitive assessment, very standardized with our neuropsychologist, Camille Luban, because we have also seen in leukodystrophy very interesting patterns like other groups, obviously, but we want to emphasize more the need to involve cognition in the follow-up and detection of cerebral ALD. This is a study with 4 time points. So patients at baseline are followed over 3 years, and with a yearly assessment, and all patients with ABCD1 and AMN are eligible, but of course no patient with cerebral ALD, because this is what we want to detect. So I will end up with that, thanking the great team from our reference center for leukodystrophy in Paris, and you probably recognize for some of you, some of the team member. Special thanks to Bernardo, who is an amazing project manager, but as well Irene and Anne-Marie for the ARISE study, Louise for, as a clinical geneticist working with me and following the patient. We also have the chance to have a psychologist, Manon, who's a precious help for many patients, and our group of students, Emo, Marianne, and Luca. Thanks also, of course, to our funders. And I'd like to say also a word about my colleague, Violetta Zujovic, who is a neuroimmunologist. We have now a team dedicated at the Paris Brain Institute looking at metabolism, immunity, and neurodegeneration. And this is, of course, of importance for this disease. And we are conducting work with Violetta on macrophage of patients with AMN and ALD. And I hope that next year she can be invited to present this data, including on the impact of some treatment like leriglitazone on these cell models. Thank you very much for your attention. And I'm happy, of course, to address any question.
Great, thanks, Fanny. That was wonderful and much needed. I completely agree about the unmet need here in the adults and the complexity. And so having a neuroimmunologist look at this is tantamount. Quick question, we've recognized in children at least that there's about 12 to 15% of self-halted cerebral ALD occurring. Do we understand that percentage in adult cerebral ALD the same way?
I think that for that, they are definitely, data being collected, particularly probably know of the study right now between Amsterdam and Stanford, addressing this question, and where we now have other centers in the US and other centers here in Europe like us who try to collaborate and provide data, because I think it's still very much in the unknown. So it's good that we have studies looking at that, obviously. But I mean, like with the finger up, I would say it could be in that range, but we have to see the data because we may be surprised.
Yeah, no, I think just on that note, that's where I do emphasize when placebo-controlled trials can be possible, they should be done. And because I think there are still so many unknowns here, and we can learn a lot from those placebo-controlled trials. The prevalence of cerebral ALD, I agree, is much higher. But you remember that the curve that is shown that should be corrected with real world data is much broader than the childhood blip, right?
Absolutely. Yeah, as I mentioned last year, a 60-year-old patient who was with no family history just out of the blue. Yeah.
So while at any given age, the risk prevalence is not as high, over 20 years, the actual numbers of patients and the prevalence is higher, right? So just to point out that it will not maybe reach the same percentage at any individual age range as in childhood, but over the 20-year period.
Yeah, but I must say that we see a lot these past years of conversion after 50 years of age. Very inflammatory, patients dying.
No, absolutely. So this data does not diminish area under the curve, right? So I think that's just something to emphasize. But we should continue talking about this.
Yeah, and monitoring. The point is that we should monitor really. And we know it's difficult for patients. It's difficult for all of us, but we are not there in their shoes to go through this monitoring. It's extremely stressful. Knowing the outcome, we are aware of that. But for now, we don't have other markers. We know that NFL is useful, but it do much more than imaging can do at the moment.
Yeah, in the US, I think the question lots of men are asking themselves, and rightly, is why should I monitor and what are my options, right? And I think that those are the questions we're facing, right? Because we all think that there should be much more data coming together, but there's, as you said, a lot of pushback from the men because they're apprehensive about the outcomes. And so, obviously there are cultural and social differences. But I think what you're showing and having new treatments emerge adds to this. And maybe through the trials, we can get more rigorous data. So completely agree.
I agree.
Julia Lier has joined us here from Leipzig. So delighted to have you come from the University Hospital Leipzig and my friend and colleague Wolfgang Krüler's team. She will present LeukoExpert, Advancing Safer Utilization of Registry Data Through Innovative Approaches. Thank you, Julia.
Thank you, Florian, for the introduction. I hope everybody can hear me clearly and see everything everybody needs to see. Today, I want to discuss the importance of data registries in rare disease, such as leukodystrophies, and how we can ensure their safe and effective utilization. Registries are essential tools in research because they help us understand diseases better, development treatments, and connect experts worldwide. However, for them to be truly effective, we must ensure that data is collected in a way that protects patients' privacy while also making it useful for research. Rare diseases present unique difficulties when it comes to collecting patient data. One of the biggest challenges in rare disease is that only a small number of patients are affected by each condition. And because these patients are scattered across multiple hospitals and even countries, the medical data is also scattered. And the medical data is also, the methods of collecting the data vary widely, making it difficult to compare cases. And it also makes it difficult to combine this data into a standardized registry. However, if we have the registries, we can really make a difference because many patients experience years and years of uncertainty before they receive a concrete diagnosis. And by collecting and organizing patient data in a structured way, we can recognize patterns and improve diagnostic processes, leading to a faster and more accurate diagnosis. A data registry is a structured database where patient information is systematically collected and stored for a specific purpose. And the concept of a data registry is not new. Like more than 50 years ago, a statistician from the World Health Organization, Eileen Burke, she defined a registry as a file of documents containing uniform information about individual persons collected in a systematic and comprehensive way in order to serve a predetermined purpose. This means that a registry must be carefully planned from the beginning, and it also have a clear goal, use standardized methods for collecting data, and be organized in a way that makes it useful for researchers, clinicians, and also patient advocacy groups. So before setting up a registry, it is essential to define its purpose. A registry should not simply store data for the sake of collecting information. It should be designed to answer specific research questions. The purpose will directly influence how the registry is structured and the methods used for data collection. So there are several common objectives for rare disease registries. Some registries aim to track the natural course of a disease, collecting information on how symptoms develop over time. Others may focus on studying the effects of treatment, helping researchers understand how well different therapies work. And some registries are designed to create like a baseline of data, to providing a reference point for future studies. A valuable resource for information on setting up a registry is the Registry Bootcamp by the Genetic Alliance, which offers guidance on best practices for registry development. Once the purpose of the registry is defined, there are important administrative aspects to consider. Key questions include who owns the registry, who funds it, what organizational structure is most suitable, and there are three primary models for structuring a patient registry, each with its own advantages and challenges. First, the centralized model. It's the most traditional approach. In the structure, like a single center is responsible for storing and managing the data. All participating sites transfer the data to this central hub where analyses are conducted. Second, an alternative model is a federated registry with a primary center. In this setup, each participating site maintains its own registry and stores its own data, but a central institution is responsible for coordination and oversight. Next, and lastly, the distributed registry. This model takes the decentralization one step further. Instead of a central hub, multiple equal partners collaborate, exchanging only analytical results rather than transferring the data. This tool maximizes data security and autonomy. The main advantage of the centralized model is its simplicity in terms of organization and responsibility. However, it raises concerns regarding data ownership, security, and server capacity, especially when dealing with large data sets such as MRI scans or genomic data. The federated or distributed approach enhances data autonomy and security as each institution retains control over its own dataset. However, coordinating data standards across multiple institutions can be complex, and the fact that only processed results, not raw data itself, can be shared might restrict certain types of research that can be performed. We can't do every analysis we want to do. The success of the registry depends not only on its structure, but also on the type of data it includes. Clinical data, such as electronic health records or clinical scores, examination findings, form most of the time the backbone of many registries. However, because much of this data must be manually entered by clinicians, it can be time-consuming to collect. Another important data source is patient-generated data, which includes patient-reported outcomes, treatment history, and symptom tracking. These datasets provide valuable insights into how patients experience their condition outside of clinical settings. However, they also require careful validation to ensure reliability. Depending on the country and the healthcare system, public data may also be integrated into the registry. This can include epidemiological information, hospital records, or even insurance data, depending on the availability and the legal frameworks, and which might differ a lot between the countries. And finally, registries are increasingly incorporating advanced data types, such as imaging data like MRI or ultrasound data, multi-omics data like genomic data, proteomic data, and these data sets require specialized storage and analysis capabilities, posing additional technical and also ethical challenges, regardless of the data type. Ensuring quality control through the continuous validation process is essential to maintain the integrity of these registries. So there are several successful examples in rare diseases, registries that have demonstrated different structural approaches. The MLD initiative, the Duchenne registry, or the neuronopathic Gaucher registry are just a few of well-established examples of well-established registries that have contributed and still contribute significantly to research and patient care. Each of these registries has adopted a tailored approach to meet the specific needs of its target's disease population and highlights the importance of flexibility in registry design. And also, in recent years, there has been a growing political effort to enhance rare disease registries. And as of March, the European Rare Disease Registry Infrastructure lists about 170 registries working to increase visibility, standardize data collection and exchange, and provide training for healthcare professionals. These initiatives aim to create a more connected and efficient network of registries, ultimately improving collaboration and accelerating research in the field of rare disease. So data registries are powerful tools that can drive significant advancements in rare disease and patient care. However, their effectiveness depends on careful planning, clear objective, and a thoughtful structural design. So let me now walk you through how we established the Leipzig Adrenoleukodystrophy registry and how we structured it to ensure effective data collection by prioritizing patient privacy and autonomy. We basically created 3 interconnected registries, each serving a specific purpose. These are linked through an organizational database that manages pseudonymization, meaning that the personal patient information is separated from medical data to protect identities. The 3 components of a registry include a data registry, where we collect clinical and demographic data, a biobank, where patients can voluntarily donate biological samples such as blood or CSF, and a brain bank, where patients can choose to contribute samples for neuropathological research. Each patient can decide which parts of the registry they wish to participate in. It also allows patients to withdraw their consent from a single part of the registries. This setup allows patients to have control over their own data while still contributing to scientific research. It also improves security by keeping different types of data separate. To manage this data, we use RedCap, a secure data management tool that allows us to connect with other registries and ensures that our system is compatible with international databases. Additionally, we have established a longitudinal data collection, meaning we track patients over multiple visits rather than just recording a single data entry. This helps us to study how the disease progresses over time. On this slide, you see an example of a patient record in our system. So each record is fully pseudonymized to ensure patient privacy. And the registry consists of different data sheets. So we have the baseline data, which is recorded only once. So this includes information about when the symptoms started or when the clinical diagnosis was achieved, also what is the specific diagnosis the patient has, but also information on the family history, are others affected, what are like the first initial symptoms the patient had, and if any like developmental milestones were reached. Also, we collect information about the genetics if available. Then for the longitudinal data, which is collected at each visit, we collect information about the clinical scores, but also about the symptoms the patients have. In the case of X-ALD and AMN, we collect information about VLCFA levels and also about the neurocognitive testing. This structured approach allows us to track changes in a patient's condition over time and then analyze disease progression. So since this session focuses on AMN X-ALD, I'd like to share some insights from our X-ALD cohort within the Leipzig Adrenoleukodystrophy Registry. So far, we've enrolled 362 X-ALD patients, of whom 254 are male. 211 patients provided consent for biobank participation, meaning that we are allowed to collect blood samples at each visit. And we have recorded 323 visits by females and 1,726 visits by males. And we have a mean follow-up of about 7.5 years for male patients, averaging on about 7 visits per male patient, and in females about a follow-up of about 5 years with 3 visits per patient on average. So looking at the data, we see that most of the patients visit us between the ages of 20 and 60. In addition to demographic and clinical data, as I said, we also collect clinical scores just as the EDSS or the AACS, which helps us analyze disease progression in different patient groups based on sex or disease manifestation. And we also collect the data from our cognitive testing from our new psychologist. So as of now, we include patient data starting from 2000 until 2025. Therefore, we cover a 25-year period now. So how did we start our registry? We basically started our registry as part of the LeukoExpert project. It's a pilot initiative designed to connect multiple centers treating leukodystrophy and multiple sclerosis patients. The goal of this project is to collect data that will be used to train an eye model, ultimately developing a diagnostic support system to improve the diagnostic process for adult leukodystrophies. For this project, we work together with in total 3 centers. So it's the Leipzig Medical Center, the Aachen Medical Center, and the Tübingen Medical Center. And together we standardized our registry questionnaires and mapped each question to terms with the HPO terminology. So the HPO terminology is like a big organized dictionary for describing medical terms and traits in a very precise way. So it provides standardized terms for symptoms. For example, hearing loss is always hearing loss, and all the variations like deafness or partial hearing loss are combined into one term. This makes it easier for different doctors and hospitals and also researchers to share and compare the medical data. And you can imagine it's like a structural map of medical symptoms that help link the patient conditions to its genetic research. And therefore, we can ensure that we have a better comparability across data sets we want to connect to each other. So rather than transferring the raw data, each center retains its own data set, and an analysis is performed locally. So this is a distributed approach. So to analyze this data, we use a system called the personal health train. This means that instead of moving the patient data between hospitals, the data stays at each hospital, and only the results of the analysis are driven from station to station, like using a train, basically. This way, patient privacy is fully protected while allowing researchers to work together. And by linking different data sets in this way, we can improve the quality of research and answer the questions we want to answer. So we are still finalizing the last steps of our analysis, but we can already show that our data proves that until today, adult leukodystrophy patients experience significantly longer delays in diagnosis compared to MS patients. The difficulty in this project is among others that leukodystrophy are a group of diseases with very diverse symptoms and progression patterns. So diseases such as metachromatic leukodystrophy is usually characterized by changes in behavior, while the typical AMN patient presents with gait difficulties or loss of bladder control. So we have like a very wide range of symptoms we are covering. But first analysis of our artificial intelligence model show that it is able to differentiate between multiple sclerosis and leukodystrophy based on the symptoms and the basic data such as sex, age at visit, or age at symptom onset. So for now, we have connected 3 stations in one country, therefore representing similar healthcare settings. However, other groups have already shown that the personal health train is able to connect multiple centers worldwide and making global collaboration possible without compromising patient privacy. So to summarize, I want to leave you with 3 key points. So So first, when building a registry, it is important to start with the end in mind and identify the aims and intentions. So this helps clearly identify the goals and objectives from the start, and this makes us easier to come up with a good structure and methodology. Second, we need to think globally, but act globally. In the case of leukodystrophies, where patient numbers are low and data is scarce, we need to maximize the use of all available data by building networks and connecting our efforts across institutions and countries. And lastly, while data protection and autonomy is always feels like an obstacle, and we all like to complain about it, they are essential. And with complex data like MRI scans or genetic data, full anonymization is impossible. So while we often like to complain about it, about the strict data privacy regulations, instead we must find ways to connect the analysis methods without transferring the data, just like we do in the private personal health train. So by taking these steps, we can create secure and effective data registries that benefit both research and patient care. And with that, I would like to thank you for your attention. And yeah, thank you.
Excellent. Thank you, Dr. Lier. This was wonderful and a great finale to these talks. It's such an important effort, and I completely agree with a federated approach where we have the opportunity to understand data across the world while obviously protecting our data locally as our institutions mandate. I'm now looking to Audrey, whether we are moving into a closed session or discussion session. How does this work?
So now all the audience is invited to rise up the hand, and if you want to ask question orally, it's easier for our interpreters. Please make your question by oral as much as you can. And we have some question in the Q&A toolbar, and I see that Professor Mochel is answering. And we have a question on Alexander disease, but Alexander disease is tomorrow. Maybe one of you want to answer this question, but Alexander disease is tomorrow, so maybe it's not this a good time to answer this one. And we do have a question from Josette, so I'm gonna open your leave you to speak. Josette, can you hear us?
Je peux parler?
Oui.
Oui.
Can I speak? Yes. I have written my question, but Dr. Mochel gave me a preliminary answer. Unfortunately, I'm not entirely satisfied. Well, I'm going to meet with her very soon anyway. I am a mother. I am a carrier and suffering myself from AMN, and I've been living with leukodystrophy since 1989 with both my sons. They've both suffered from ALD and AMN, and they died in 2004 and 2010 at 24 and 36 years of age. I took the floor in Luxembourg to show the forms of a carrier mother pathology. It was maybe 2-3 years ago. I can't remember. My question is the following. I am 73 years old. It's critical age when one starts experiencing pain. And although my symptoms are like my son's symptoms, I have also other symptoms. I have been talking to other mothers. I know that other mothers are suffering from those symptoms, but we don't know whether they are directly connected to the disease. Do you have any information regarding the symptoms which are typical for carrier women suffering from AMN at my age? Can I answer? Well, if I'm allowed to. Is it okay? Can I answer?
Donc oui, pour l'instant, vous n'êtes pas encore venu dans notre centre, donc
well, you have not visited us in our
voilà, je
center,
comprends bien qu'il vous manque
so I
encore beaucoup
understand
d'informations,
that there is a
mais
lot of
ça
information
sera,
you
voilà,
haven't
on
had
va faire une
access to
consultation,
yet.
bien sûr,
So I'm not
de
going
tout
to
ça, mais on
obviously
comprend
give
bien sûr
you
de plus en
a
plus les différentes manifestations de la maladie. Et
a
ce que j'essaie
private
de répondre bien
consultation
sûr rapidement,
on during the
mais qui est
meeting,
une
but
réponse
just to
très partielle, c'est
answer
que
quickly,
en
this
dehors
will
des
be a partial
observations
answer.
cliniques qu'on peut
As,
avoir,
apart
Dr
from the
Yazbeck, là,
clinical
qui a aussi
observations,
travaillé
and Dr.
plusieurs années
Yazbeck, who is here, has
dans
been
notre centre, connaît
working
très très bien ces
in our
symptômes
center
chez
for
la femme
years
aussi,
and
elle
knows the
peut se retourner en
symptoms. She's
pédiatre.
fully familiar with the
Donc il y a
symptoms,
ce que
and
nous on
although she,
observe, et puis il y a
for
ce que les
women,
études
although
nous
she's a
montrent petit à petit, et
neuropediatrician
donc nous
herself,
permettent
and
d'avoir
so
bien
there are
sûr
trials and
une
studies
harmonisation
showing
dans la
us
façon de pouvoir
that we
étudier
can now
toutes ces
standardize and
manifestations.
harmonize the
Et
way
donc on
we
sait
work
qu'au-delà
on
des formes de
symptoms.
myélopathie, donc des
And
atteintes que peuvent avoir
outside
certaines
of
personnes
the
de type qui ressemblent
myelopathy
aux hommes,
type
notamment sur la partie spastique, sur la partie limitation de la marche, du
symptoms
facial
as
odor, il y a
spastic
d'autres
and
symptômes qu'on voit beaucoup
stiffness
plus chez les femmes,
that
notamment sur les
limits
myélopathies,
the capacity to
donc
walk.
avec les
There
douleurs
are
qui vont avec,
also
mais aussi sur les
other
flux
kinds of
vésico-intestinaux qui
neuropathic
peuvent être
symptoms,
dissociés des problèmes de cœur,
sphincter
alors que chez les hommes, ils
associated
sont
issues,
souvent associés. Donc toutes ces choses-là, on est en train de
although
les
these are
étudier, et on
frequently
pourra vous en reparler bien
observed in
sûr plus en
men,
détail
and
autour d'un
we
tour
are
de vote qui
studying
sera à
those
vous, puisque ça
symptoms, and
reste
we
bien
can
sûr
tell
d'une
you in
personne
more
à une autre
detail
très
what exactly
variable.
it is that you're
Mais ce que
suffering
l'on
from,
sait, c'est
because
qu'on
it's
a
very
beaucoup
different from one
sous-estimé
patient to
ces
another.
manifestations,
However, we have
et
largely
notamment l'étude qui avait été faite par le
underestimated these
centre de
symptoms in the
Markengelen à
past.
Amsterdam, qui
Mark
était
and
allé
Gellem Center in
regrouper en
Amsterdam
fait
made a
des
study
personnes
and
porteuses, mais
actually
qui n'étaient
called
pas spécialement
back
suivies pour des symptômes,
women who
et
were
montrer que si
carriers
on
but
faisait des
had not
analyses
been treated for symptoms
électrophysiologiques
until
pour aller
then,
justement
showing
regarder le
that if we
contrôle urinaire
perform
ou certains paramètres de
electrophysiology
conduction au niveau de
examinations
l'albumine,
to
il y
check
avait des
urine
altérations.
control
Et donc c'est
or
pour ça
conduction
qu'on a
issues,
l'impression que c'est
there
vraiment un
were
spectre, mais que les
alterations
femmes
and they
peuvent
could be
être à des degrés
observed.
très
So
variables,
yes,
toutes un peu
women may
concernées à un
suffer
moment
from
donné
the
de leur vie.
disease
Alors
at
bien sûr,
different
plus on
degrees,
avance dans
at
l'âge,
different
plus ce
stages in
risque ça
life.
se
And the older
développe.
you get,
Et c'est vrai que
obviously, the
les symptômes
greater
sur
the
lesquels
risk
on
of
est
the
aujourd'hui
symptoms developing.
encore
And the
vraiment très peu
symptoms that we
utilisés, c'est
are
sur
not
les
very
dimensions de douleur. On en a bien conscience, y compris
well
quand on fait des électromyogrammes qui sont
equipped to
normaux,
treat
y compris quand on fait des
pain
autres
symptoms, although
études
sometimes
cérébrales ou éducatives où même pas
electromyograms
encore, et on
might
espère
be
qu'avec cette
normal, but
étude
there
que je
is
vais
pain.
montrer là sur
And
les
now
panneaux
we have other
d'imaging, on va
kinds of
mieux comprendre ces
examinations, and
aspects-là.
I hope that
Mais
with
c'est
the
vrai qu'on a
imaging
tout à fait
techniques,
conscience, et
we
on en parle
will
avec des algologues,
acquire
hein,
a
on est
better
spécialisé de la
understanding.
douleur
We
aussi,
are
on en parle
talking
avec d'autres
to
experts
pain
en neurologie
specialists,
sur
we
ces
are talking
thématiques,
to
que pour l'instant,
neurology
c'est encore
specialists, and we're
voilà,
trying to understand what
malheureusement
exactly is happening.
assez mal pris en charge par notre communauté,
Unfortunately,
et on espère bien qu'avec
I
tous
know
les
that
efforts internationaux qu'on
this
met ensemble, et
problem is not
ces réunions là sont
sufficiently
l'occasion de
dealt
pouvoir
with, and
présenter des
these
résultats,
meetings are a
et que
very
petit
good
à petit,
opportunity
bien
to
sûr, on va avancer
introduce
dans ces
new results,
connaissances.
and
Donc
we hope that we will
cette
be
discussion sera à
acquiring
reprendre
a
quand
better
vous serez venu,
understanding
bien
in
sûr.
the near future. So we will discuss this when you come
Avec
for your
plaisir.
examination. Thank you very much.
Yeah.
My pleasure.
Maybe I can just add another comment. I think Professor Mochel is absolutely right that it requires in-person detailed examinations to understand this. When, as Josette points out, with age, it is harder to then distinguish what is ALD from what is normal aging. And I think one has to be careful not to prematurely jump to the conclusion that everything is ALD. And I think that is where good neurological evaluation is important. We just published in neurology this year the prevalence of various different symptoms in our female cohort that I'm showing here. And I think many centers are doing this. I know Amsterdam has been pioneering in doing this, but I think it helps have providers understand how to sort out what it might be ALD related and what might not be. But we need far more data to answer these questions.
Si je peux juste rebondir sur une question qui est en ligne là sur le monitoring
add something because I see a question online regarding IRM monitoring for female patients. This is not something we do as first intention examination. I talked about a research work to understand the disease and the natural course of the disease, and also to try a new therapies that are either being developed or already being tried for men, but we don't recommend a systematic MRI monitoring because, again, the frequency is very limited. It's about 1% of the cerebral form. So we don't do the exam systematically. We only do it when there's a clinical issue, when there's a clinical uncertainty. And in all our centers, we have 1 or 2 women who unfortunately develop the cerebral form of the disease. But again, that is based on the fact that there are atypical clinical signs that warrant this type of examination, or if we have a doubt also, we will conduct examination just to make sure that the patient doesn't actually suffer from the cerebral form of the disease.
Yeah, I think, Fanny, that's a very good point. I will say that we get one baseline MRI on all women who come to our center. And the other thing we pay attention to, we don't monitor these patients, as you said, by brain imaging over time. But if they have adrenal insufficiency and the very long chain fatty acids are elevated in the male range, we become very suspicious. And we've had 3 women who've developed cerebral ALD who have succumbed to the disease. So we're very, very careful about this. But I think it's important to compare notes here over time. It's the tension is between what we know and what we don't know. And I think, as you said, Fanny, when they're symptomatic, it's you definitely have to image for clinical reasons. But now we understand that there are certain also clues that are warning signs for us, and we act very quickly on those.
So we have another person who would like to take the floor. So it's Sylvie Lips. Let's see. Up.
Sorry, I can't read the Japanese. It'd be wonderful to have a translation of the Japanese, if at all possible.
Yeah.
Hi. This is a
Unfortunately, I am not Japanese myself. Can you hear me?
Yeah.
Oui?
Yeah.
Yes.
Vous m'entendez?
Okay. Yes, you can hear me.
Je suis belge.
I am from Belgium.
Malheureusement,
Unfortunately,
je suis atteinte et
I
je transmets malheureusement
suffer
donc
from
je
the
suis
disease
atteinte
and
d'adrenomyeloneuropathy.
I suffer from
J'ai 62 ans.
A&M, and I'm
Les
62
symptômes
years
ont
old.
commencé vers
And the
55
symptoms
ans.
started when
Et
I
ce
was
n'est pas dû
55.
à ma vieillesse parce que je me
So it
considère
wasn't
encore
really
jeune.
an
Donc,
age-related
perte
issue because
d'équilibre,
I'm relatively young still.
incontinence
I started
védicale
having
et
balance
fécale,
issues,
c'était beaucoup plus
bladder
difficile.
incontinence,
Je
but
suis suivie
also
par un
fecal
neurologue
incontinence, and that's a bit
à
more of an issue.
Bruxelles, donc
I
en
have
région néerlandophone.
a neurologist in the
Et j'ai 4 enfants.
Dutch-speaking part of
Alors,
Belgium. I have 4
il
children.
y a 15 ans,
15 years ago,
grâce entre guillemets, malheureusement, au fait que
unfortunately,
mes
due to
enfants
the fact that my
été diagnostiqués
son had
par
been
cette mutation
diagnosed
génétique
with this genetic
qu'on a
mutation.
diagnostiqué au bout d'1 an de recherche.
It took
Donc
1 year
moi,
to
en tant
find
que
the genetic
maman
mutation.
de 3
As a
garçons et d'une
mother
fille,
of 3
j'ai
boys
donc
and 1
dû
girl,
faire les tests.
I
J'ai
had
malheureusement 2
to
fils
submit
qui
myself
sont
to the
atteints
tests,
par
and
la
unfortunately,
mutation
it appeared that
génétique,
2 of my
qui
sons
pour le
had the
moment
genetic
ont
mutation.
une insuffisance surrénale qui est tout
Right
à
now,
fait
they suffer from
régulée, enfin
adrenal
régulée, non, qui est tout à fait
insufficiency,
traitée
but
par un
it's well
endocrinologue
controlled.
ici
They are
dans une université
being
belge.
seen by an endocrinologist here in the university in Belgium, and
Bon,
the
ma
adrenal
question,
insufficiency is
ma
well
question
controlled. But my
fondamentale,
question,
j'ai un autre fils
and I have
qui
another
lui
son.
n'a pas cette mutation génétique, mais
He
malheureusement,
doesn't
on
show
lui a
the genetic
découvert
mutation. However, we
allez, non, une pipe.
can't remember the word. He was found to suffer from, I'm sorry, I'm so
la sclérose en plaques.
emotional. He suffers from
Donc,
multiple
voilà,
sclerosis.
c'est déjà pas mal. Et ma fille
And my
va
daughter
bientôt faire le test pour savoir
is
si elle
going
est
to do the
éventuellement
test
connectée,
herself
puisqu'elle est
just to
en
check
âge
whether she's a carrier, because
de
she
vouloir avoir des
is
enfants.
at an age when
Donc,
she
ma
would like
question
to
est,
start a family, so she will
parce que je
submit
suis
herself
ça
to the
de
test.
très près,
And my
est-ce que
question
mes 2
is,
fils
are my 2
atteints
sons
par
who
cet Amen, j'ai bien compris qu'ils
have
pourraient développer
have AMN,
mais vont-ils
could they develop,
d'office
I understand they could, there is a risk that they will develop ALD, but
vont-ils d'office avoir cette paralysie des membres
will
inférieurs?
they systematically suffer from the limb paralysis?
I don't know, but I can briefly answer. as Fanny, Professor Mochel, and others have pointed out, there's overlap in adulthood of AMN and the risk of developing cerebral ALD. So I think if the question is whether you can lose lower limb function, the answer is you can lose lower limb function due to either one of these manifestations, whether it's affecting the spine or affecting the brain. But I would talk to your neurologist and have ongoing monitoring happening, and that will help you with understanding the future.
Absolument. Mais mais ma question,
right. I understand. My question was a bit different. My question is, I have two sons, and they both have the XQ28 mutation. And when they were diagnosed 10 years ago, I was told that there was this Damocles sword, and that eventually they could very well develop paralysis of the lower limbs. And today, from what I'm hearing, also from what I have been reading, my impression is that there is a quasi-certainty that they will develop this paralysis, and that is what I'm trying to pinpoint. I understand, says Fanny Mochel. I was trying to answer one of the patients, another patient, at the same time. I'm managing the chat and the live questions at the same time. I apologize. What we do know is that as far as myelopathy is concerned, and the affectation of the central nervous system in man, the likelihood to develop symptoms during their lifetime is 100%, which means that all man during the course of their life will have symptoms. I'm talking about myelopathy. I'm not talking about CALD. I cannot hear you well.
Do you have any trouble hearing me, Florian?
Professor Mochel, are you in the French channel when you're speaking in French?
I don't know. I just didn't change anything. I can.
No, it's okay. It's okay now.
I can talk. You prefer me to talk into English or French? Just tell me.
I think for the translator, it's better if you speak English.
English, okay. So I was saying that we're talking here about the myelopathy, and obviously that I was talking about the concept of penetrance, which is the risk to develop symptoms during the time course of life. And so for the myelopathy, not for the cerebral form, we know that it's close to 100% in men, but it can vary a lot in terms of age of onset. And we do have the majority of patients starting between, we say, usually 20 and 40 years of age. That's what we all said in guidelines. But we do have patients who start very, very late. And as I mentioned, just last year, we encountered a patient who had a very severe cerebral form of the disease from which he died in just a year. And he had only just, for him, he had no motor symptom. He was doing sports, he was extremely active in his life, and on examination, we could see that he had some mild proprioceptive, so a reduction of the sensory system that was not affecting his daily life. So it's just to say that it's a wide range, and for now, we don't have tools to predict the age of onset, like Dr. Yazbeck was saying earlier. We don't have tools to predict if the cerebral form is going to affect the children or the adults. So yeah, when you were talking about paralysis, about loss of ability to walk, this is really an end stage of the disease. And there are many patients that we know of who don't go to that stage. Of course, we know of a lot of patients who do as well. So it really is very variable, but if you go up to 70 years of age, if you examine a man, he will have some symptoms, but it can be very broad.
D'accord, écoutez, je vous remercie. Je vais pas vous tenir
Okay,
plus longtemps.
many thanks. I'm not going to keep the mic. I appreciate your answers.
L'avenir le dira
The
et
future
je
will
suis
tell.
une maman, donc
I am a
But it's
mother.
important that your sons...
J'accompagne mes enfants là où ils iront.
Of course,
I'm
and thank you for your
supporting my
question. It's
kids.
just important that they have some follow-up with neurologists and that the neurologist is aware that they should have some brain MRI.
Absolument.
Yeah.
Tous les 6 mois, ils sont
Every 6 months, they're being monitored. Thank you so much for your answer. Very much appreciate it. It's fascinating, difficult, but fascinating. Thank you.
Thank you. Just I have the translation for the Japanese written. So this is a Japanese patient group. Our patient group has reported that they have more leg pain than women who are carriers of the disease. And we have been showing a YouTube video of a certain exercise routine that we believe will improve the pain. So what methods does your team use to follow up with the families of patients who test positive for newborn screening?
So Audrey, you were referring in your translation both to, because the question is following newborn screening. So I'm thinking we are talking about children, but the tests that you are mentioning, exercise, are they for adults? Can you?
So the first YouTube part was about saying that they have a YouTube channel where they are explaining which exercise they have. And so the second one is about newborn screenings. The first one, there is no question.
Maybe let's do it. Oh, I see. Okay. Maybe we can separate it.
Comment on the exercise part, and then of course I'll let the pediatrician answer for the newborn screening. But for the exercise part, this is I mean I have no access right now to the YouTube link, but it's definitely excellent because of the very strong metabolic component of this disease, and that we know how much of mitochondrial involvement there is among other pathological mechanisms. And we know how much exercise is helping in general on neuroinflammation, but also mitochondrial function, a little bit the same things that actually some drugs are addressing. So we definitely have to do more in this regard. And there are, I mean, sometimes dedicated physiotherapy program that are developed. We do not have one specifically on our own, but of course, if there is research in that direction, I mean, it's very important. But I let the pediatric comment as well, of course, to someone else.
Maybe Élise, you want to take the pediatric comment?
About the follow-up of the symptoms, or about the treatment of the pain?
Audrey,
about newborn screening. Yeah.
Audrey, can you read the question again?
Sure. What methods does your team use to follow up with the families of patients who test positive for newborn screening?
Okay. We still don't use the newborn screening in France, but when we diagnosed a baby that is still asymptomatic, we see the family for the first time, and we explain all the follow-up that will be done after. The first thing we say is that at few months of age, we will have an endocrinologist follow-up, because every 3 to 6 months we must do the blood work for the adrenal insufficiency. And then we tell them that from 2 years age, we will begin the follow-up of the brain MRI every 6 months to seek an eventual child cerebral ALD. So we see them in the referral center at least once a year, and we expect from them to have an MRI twice a year. And also a neuropsychological evaluation, I forgot, once a year after beginning the school.
Thank you.
I think in the US, it's very similar, where we do have newborn screening. I think the one challenge we are now facing with newborn screening is to point out that not all variants that we are identifying on newborn screening are as clearly penetrant as we previously thought. And so just to add to what Fanny said, the landscape is changing for us. So we are probably shifting a little bit more towards evaluating the variants and moving towards LISO-PC C26 evaluation to become more certain about pathogenicity. But then we very much follow what Élise said, that we get yearly MRIs until 3 and then every 6 months until age 12, and then shift back to yearly after that age.
And functional studies in fibroblasts when needed, right? For certain further variant pathogenicity, like the Dutch program?
The Dutch program does that. Much harder to scale up now with thousands of kids screened across the U.S. So we don't do that.
No, but maybe of course for the class 3, the variant of unknown significance.
Yeah. Yeah, no, you're right. Sort of on an individual basis. I think the database from Stephan Kemp is also a very valuable resource. So adrenoleukodystrophy.info is what one should look at if one has questions. Hope this helps.
We have requests about the link. So Rioma, if you can send the link you've mentioned for the YouTube, we will share in the chat. We are going to take the last question from Maxime Dubourg, and after we are going to try those breakout rooms.
If I may, Audrey, Maxime is a patient of mine who has another leukodystrophy, and I answered privately to his question.
Okay, so
he has a CSF1R related, so it's just not the topic right now.
Okay, so you've answered. Okay, so I don't leave him to speak. Okay, thank you.
I'm just answering a question that maybe Florian, you have more data on that I do. Questions from Alessandro Magis. What percentage of children who undergo transplant or GT develop adult onset AMN? So I was just saying that we know that these treatments do not prevent AMN, but I don't think we know the frequency, right?
That's correct. So yeah, and Alessandro, also my patient. So I think there's very little data on the occurrence of adrenomyeloneuropathy after bone marrow transplantation. A small study done in University of Amsterdam to address this years ago. But I do think this needs to be revisited in the modern era where some of the management and chemotherapy has changed. And for sure, we don't understand what happens after ex vivo gene therapy to the spinal cord. There is, of course, hope that introducing new microglia-like cells to the brain will also support the corticospinal tract and dorsal columns, but it's too early to say for sure what remaining risk there is of having AMN.